Ashley, is Dr. Dion going to be joining us?
I did send a link and I'll follow up now.
No problem, no problem. Great stuff. And while we haven't started, we know that we've got um, funders. Sulfade has been doing a great job in funding us, and
Yeah.
also Legacy Medical in funding some of the activities we have. And we
Mm.
thank you so much. All right, it's 3 o'clock. Welcome, everyone. I'm so excited to welcome again our beloved Dr. Verenga. It's Friday again. It's Verenga time. Dr.
Ah,
Verenga, take over.
thank you.
You can start, Dr. Verenga. Today we're doing multiple pregnancy assessment. Dr. Verenga, the stage is yours.
Thank you so much, Dr. Dakalo. Like Dr. Dakalo said, um, we'd like to appreciate the sponsors, Surface, for the wonderful job they are doing in sponsoring these meetings. And I'd also like to express my gratitude to Fetal Foundation Zimbabwe and Fetal Foundation UK, who have really supported us to practice fetal medicine in Zimbabwe. And thank you so much, Dr. Dakalo and the Pelvic Floor Foundation for doing all this. It is a pleasure, and again, it is with passion that we would want to share our knowledge in ultrasound with the rest of Africa. So thank you so much. I'm just waiting for my slides share to start, but today is on multiple pregnancy. People may wonder, why do we have to cover multiple pregnancy as a topic on its own? But the basic reason for doing this is because multiple pregnancies are special. It is not just two babies in there, but there are other things which are involved, which we all have to understand. Today, I didn't put a pre-test because it's multiple pregnancy, but I'm just going to go straight into the talk, and I'm going to emphasize certain points on multiple pregnancy. One of the reasons why we have to do a special focus is because the incidence of multiple pregnancy is on the rise. We know why it is on the rise, because IVF, of lot, of course, they are putting control measures now, but before IVF, people used to put 2 to 3 embryos there, and the number of multiple pregnancy increased dramatically in the West, so that the figures for multiple pregnancy are now being quoted around 1% of the pregnancies. This is how much multiple pregnancy have increased over the years. One of the reasons why we have to focus on multiple pregnancies is because they are associated with the high risk of both maternal and perinatal morbidity and mortality. That is multiple pregnancy. So the issue is, what are the maternal and perinatal risks? We already know from midwifery or obstetric practice that hypertensive disorders of pregnancy, anemia, cesarean delivery, and postpartum hemorrhage are more common in women with more than one baby than those with one baby. And also the issue of prematurity, low birth weight, respiratory distress, and perinatal deaths are also more common in women who have more than one baby than those with one. So as a result, we really need to understand how pregnant women with more than one baby should be looked after, because by looking after them well, we can try to address especially the perinatal issues that are involved with multiple pregnancies. I thought I need to remind people of embryology. I don't know the medical schools that many of us went to, but I went to one where we were using Langman's embryology to be taught embryology. So this picture is from Langman. So I want to explain certain concepts to do with multiple pregnancy, which are normally not understood well. First of all, we have these two terms. We have zygosity. So we have a monozygotic and dizygotic twin pregnancy, or triplet or multiple pregnancy, right? When we are talking of zygosity, we are saying it has come from how many zygotes. So a twin pregnancy, triplet or quadruplet, that has come from one zygote is called a monozygotic pregnancy. Then the one that comes from fertilization of 2 ovums by 2 sperms, it becomes a dizygotic pregnancy. We can never tell clinically whether a pregnancy is for sure dizygotic or not, because a monozygotic can end up as a appearing like what a monozygotic looks like. So the zygosity issue can probably be answered more in the case of monozygotic twins. But as for the dizygotic, ultrasounds can appear in such that monozygotic and dizygotic can appear the same as you've seen in my explanation. So for dizygotic twins, it is very simple. We have 2 eggs with 2 sperms which are fertilized separately. So in other words, we have 2 babies who from the beginning, there were 2 different eggs and 2 different sperms that fertilize each of the eggs, and we end up with 2 babies. These babies, they are going to have separate placentas. This is very important. They are going to have separate placenta. This is what you call dichorionic, diamniotic. So we are saying babies who are separated, 2 eggs, 2 sperms, we end up with what we call dichorionic diamniotic from a dizygotic fertilization. Then the placenta may sometimes fuse if they are close to each other. This does not change. They are still dichorionic diamniotic twins because they are formed from 2 different eggs and different sperms. So this will remain dizygotic despite that the placentas are fused and they are separated with a thick membrane because the chorion is in between. So this remains a dichorionic diamniotic pregnancy. So you may have a situation where the placentas are clearly separate from each other, or we may have a situation where these placentas are fused, but we know from formation that these placentas were formed differently. This is where ultrasound scan is very important now for us to be able to distinguish this from a monochorionic pregnancy. Let's go to the monozygotic. The monozygotic pregnancies, we are saying the pregnant were, at first, it was just a 1 egg and a 1 sperm that will fertilize each other. After fertilization, if the egg, if the zygote divides within the first 3 days of fertilization from conception, remember when we were talking about conception, the division has occurred within 3 days. What is going to happen? We're going to have 2 separate cell masses, and this will grow to become dichorionic diamniotic pregnancies. So you can see that amongst the dichorionic diamniotic pregnancies, we can still have the monozygotic in there. So you cannot tell for sure whether the pregnancy is dizygotic based on ultrasound findings. This is very important. So based on ultrasound findings of a dichorionic pregnancy, you cannot tell the parents that, look, your twins are not identical, or neither can you be sure, because monozygotic can also end up as dichorionic diamniotic pregnancies if they divide on day 3. But if this zygote divides from between day 3 to day 9, it will end up with 2 cell masses which are within the same cavity, that is the chorionic cavity. So in this case, we have 2 chorionic cavities. In this case, we are going to have 1 chorionic cavity, but at the same time, we are going to have 2 amniotic cavities. So we end up with a dichorionic, monochorionic diamniotic twin pregnancy. Then we have a situation whereby the division of the zygote is very much delayed and it divides between day 9 and day 12. If this occurs, we're going to have a single cell mass, but with this single cell mass, what it means is that we are not going to have an amnion. So these twins are now monochorionic and monoamniotic. They are in one sac, one monoamniotic sac. Then the third scenario division occurs after day 12, and we end up with the conjoined twins or Siamese twins. So what do we learn from this graph, from these pictures? We learn that we cannot for sure tell a woman that we have dizygotic because we have seen that the babies are two separate sexes. So zygosity is not something you cannot be certain on ultrasound, except in the case of monozygotic twins. Then the second point, we cannot tell chorionicity because there is a dividing membrane. Because you can see that in monochorionic diamniotic, the dividing membrane is present. So the presence of a dividing membrane on its own cannot say this is a dichorionic because you've seen a dividing membrane. Now the question is, how do we then determine chorionicity? Then for the monochorionic twins, there's a problem which I want you to understand, that in monochorionic, these twins which I've mentioned here, these are monochorionic because the placenta is shared for these twins, including the conjoint. So what happens with the conjoint is that the vessels from the two twins, they actually communicate. We have the arterial to arterial communication, then we have arterial venous and venous communication. It is the imbalance that occurs between this sharing of vessels, the unequal sharing that occurs in these vessels, that will lead to the complications which I will describe in the presentation, that include twin-to-twin transfusion syndrome, selective fetal growth restriction, and also twin anemia polycythemia sequencing. These complications arise in monochorionic pregnancy. Then in terms of the complications, if we were to compare the monochorionic versus the dichorionic pregnancies, this is from the Fetal Medicine Foundation studies. So if we look at the actually it's from the paper which was published by these guys in ultrasound scan, and also from the studies done by Professor Kipros there. So if we look at the complications and we say dichorionic versus monochorionic, we can see that in monochorionic, the risk of miscarriage is actually 10 times higher than the dichorionic. Then in terms of preterm is 2 times higher, and also in terms of fetal growth restriction is almost 4 times higher, and mortality is almost 2.5 times higher. Then in terms of fetal demise is almost 3 times higher, and fetal death is 2 to 3 times higher. What is this table telling us? This table is telling us that the outcome of pregnancies when it is a monochorionic is totally different compared to a dichorionic. Therefore, it follows that we should do our utmost diligence to identify monochorionic pregnancies, so that we separate twins who are otherwise dichorionic from monochorionic, because the monochorionic are going to require a different kind of care plan. To just show you our own data from Fetal Medicine Unit, where we had 1,150 pregnancies scanned, and out of these 1,150, we had 74 twins, and with outcome on some of these twins. So this is just to show you that twins were actually about 7% from our cohort, because we are quaternary center, so we're about to have a higher number of twins there, and we also have a dedicated twin clinic, multiple pregnancy clinic in the Fetal Medicine Unit, and 1% of them were multiple pregnancies. This is just to show you the demography, but I want to show you division of these twins according to chorionicity. A third of the twins were actually monochorionic, and the other 61% were dichorionic, which more or less agree to global figures. And we also have the ones who are unknown, where we couldn't determine, because sometimes the woman will present too late for you to determine that. Then, of course, 1% was actually monochorionic monoamniotic pregnancy. Then when you looked at the complications from our own series, we do not expect dichorionic to develop TTTS. This is where there's nothing there. Then in terms of fetal growth restriction, it was 8% of the twins at TTTS, which is twin-to-twin transfusion syndrome. Then if you look at the selective fetal growth restriction of both, in monochorionic, 8% of them they had selective fetal growth restriction while it was 0 in dichorionic. Then selective fetal growth restriction, this is a term which I would define. Selective, that means one of them is affected. It was 28% in the monochorionic group and the 16% in the dichorionic group. Single IFD, again, it was higher in the monochorionic, and double IFD, it was higher, and discordant fetal anomalies was 12%, it was 6 times higher in the monochorionic group. So my message is just reinforcing that reinforcing what we're saying, that look, monochorionic pregnancies are likely to have more complications compared to dichorionic pregnancy. This is to show you more of the data. The data is just reinforcing what I was saying, that complications are more likely to be more there, including preterm birth, if we aggregate this figure. Of course, in our series here, the dichorionic seem to have been delivered more, and we didn't do better in terms of cesarean section here. But overall, all we are saying is that more complications are more likely in babies who are sharing the placenta than those who are not. This is just more data on it. Then I've just proved a case here that, look guys, monochorionic pregnancies are totally a whole different ball game compared to dichorionic twin pregnancies. Hence, monochorionic pregnancy should be identified very early on in pregnancy and be cared for differently compared to dichorionic pregnancies. The question now is, how should we then do it? When they come at first in first trimester, we have already presented the first trimester biometry when you did biometry. But one of the things that we do in first trimester in twins, which you don't do in singletons, is that we want to label the twins, because we should be able to label the twins from very early on when they come to us. And how do we label the twins when we discover that there are two twins there? How we label is that the fetus who is close to the cervix should be twin 1, because normally in first trimester, one is on top of the other and one is very close to the cervix because of the shape of the uterus at 12 weeks. So when you scan babies, you are going to see there's one who is closer to the cervix, one a little bit further from the cervix. Then if the twins are a little bit bigger, then the fetus who is on maternal right is fetus 1. And we can also use placenta condensation, that the placenta which is inserted more on the right becomes the twin of the placenta inserted more on the right becomes twin 1. And we can also do fetal sex labeling, that is if they are above 16 weeks, and we can identify the gender of the baby. But labeling should be done. That means when you are scanning twins, you should label and say twin 1. How did you identify twin 1? So that the next person who scans these babies will know who is twin 1 and who is twin 2. Otherwise, without labeling, there's going to be confusion in assessing the growth of these babies. Then dating. When you are dating twins, how should we then date? So when you are dating twins, we measure the CRL of both twins. Then the twin who is bigger is the one who is going to be used for dating the pregnancy. So we are going to assign the date of the pregnancy using the bigger twin. We don't use the smaller twin, because the smaller twin could mean that the could be because of selective fetal growth restriction, very early onset selective fetal growth restriction, and could also be due to twin transfusion syndrome, and could also be due to aneuploidy, that is chromosome abnormalities like Edwards-Fetal, and also triploidy can cause a baby to be smaller than what it should be in first trimester. So you do not assign two dates. You are going to assign the pregnancy dates using the CRL of the bigger twin. You don't write on your report that the due date is in the bigger twin is this, the due date is in the smaller twin is this. You assign the date is in the bigger twin. Chorionicity determination. This is the most important aspect of twin scanning. Because I've already proved a point to you that monochorionic twins is a disaster. Hence, we need to identify monochorionic twins so that we can give them the right care. So how then do we determine the chorionicity in first trimester? Which should be the time at which we see these patients so that we can determine it properly. So when you are doing the scan, early on, if you are using a very good machine, the modern machine, the Volusons, the Toshibas, which are adapted for first trimester scanning, you are going to see that for dichoronics, you are going to see where the membranes meet at the level of the placenta. If the placentas are two and they are separate, it's very simple. It's a dichoronic. But the problem comes with the fused placentas, as I've already shown you that fused placentas can be due to dichoronic or monochorionic. So for the fused placentas, what you are going to see is that where the membranes meeting, the chorion is going to invaginate a little bit into the membrane. Of course, the membrane looks a little bit thicker, but because there's no nomogram for the thickness of the membrane, it's not a reliable sign for you to use. But you have to see where they are meeting there, that there is some invagination of the chorion, and you are going to see the amnion actually still separate, not yet fused, because normally the amnion fuses with the chorion around 15 weeks. So before 15 weeks, you are going to see that there's actually an amnion which is coming to join the chorion at a higher level there. But later on, because the amnion will have fused together with the chorion, you are going to see that there's invagination of the chorion into the dividing membrane there. So this is what you call a lambda sign. This is a lambda sign, the invagination of the placenta tissue into the dividing membrane. This sign should be looked for when you scan babies before 14 or before 15 weeks. It's a first trimester sign. Sometimes it disappears in second and third trimester. So if you get an opportunity to scan babies in first trimester, please go and look for this sign, because chorionicity is the most important determinant of pregnancy outcome in multiple pregnancy. So that's dichorionic. Monochorionic, then how do we separate from this? Because in monochorionic, we said there's only the amnion, the chorion is not there. So you are going to see there's very thin membranes without any placenta tissue invaginating inside. If you are using a very good machine, especially if you are doing transvaginally. So you are going to see this. Later on in pregnancy, what you are going to see is a T sign without any placenta tissue invaginating into the membrane, dividing membrane there. We call this the T sign. This is the T sign. So there's a difference here. You can see there's a clear difference between this image and this image, between this image and the other image. So this is for monochorionic. So dichorionic, monochorionic. This is very important. If you do a scan for multiple pregnancies and you don't tell us the chorionicity, you have not helped us in management of the pregnancy. So if the placentas are two and they are clearly separate, fair and fine, of course, at fetal medicine level, always say be careful with the second placenta, because twin pregnancies are susceptible to bilobe placenta. So you should always be careful and interrogate the other placenta and make sure the membrane is in, the cord is indeed inserting into this placenta, because it could be just a subcentrate lobe or an accessory lobe, a bilobe placenta, which is a single placenta. So you should always be careful with the number of placentas. If we cannot determine chorionicity for one reason or another, we assign monochorionic diamniotic pregnancy labeling. So if we can't determine chorionicity, the pregnancy would rather be managed as a monochorionic than a dichorionic. Cord insertion can also be used in very difficult cases, also more so for monochorionic monoamniotic. Monochorionic monoamniotic pregnancies, this diagnosis should ideally be made in a specialized unit or a fetal medicine unit, because most monochorionic monoamniotic pregnancies which are labeled as such are actually monochorionic diamniotic, which have TTTS, where the membrane is now fused to the other twin and they are missed. Most if they are scanned outside the specialized center. So monochorionic monoamniotic pregnancies is a specialized center diagnosis. So if you think the pregnancy monochorionic monoamniotic, please refer to a specialized center. You could be missing twin-to-twin transfusion syndrome there. Right. Then, of course, I've already told you that the CRL should be compared. If there's a discrepancy of more than 10% of the CRL, then the babies will need to be referred, because you could be dealing with a case of early onset fetal growth restriction, or you could be dealing with a case of twin-to-twin transfusion syndrome, early onset twin-to-twin transfusion syndrome, or aneuploidy. So they will need to be referred if the discrepancy is too much between the CRLs. And of course, you also compare the NT, but this is beyond the basic course. But I want you to know, because I understand there are students here, you also compare the NT of the two fetuses. We also compare the ductus venosus. If the ductus venosus are like these are some of our babies there, there is such a discrepancy where the ductus venosus is a reverse A wave, then in this case, we need to suspect that there could be TTTTS in monochorionic pregnancies. This is beyond basic. I'm mentioning it just for the sake of the student because of the questions that I've been getting in previous talks. Then in terms of the complication, I've taken you through the complications. Then therefore, that means when you are scanning twin pregnancies, we should be screening for complications. So what complications should be screening for each of the twins? As far as fetal growth restriction, both monochorionic and dichorionic will need to be screened for this. As for TTTTS, this is a disorder of the monochorionic pregnancy. It's not a disorder of the dichorionic, so you don't need to worry in terms of TTTTS there. Then twin anemia polycythemia sequencing, which is another abnormality. I'll describe it in brief, how to suspect it, but I'll not go in detail because of the course. This is a problem of monochorionic because of the unequal sharing of the placenta. So you don't see it in dichorionics. Then preterm birth is prevalent for both. It's more in monochorionic, but it's prevalent for both. Then discordant fetal defects, they are both can okay, but they are more common in monochorionics. So we need to screen for all these defects. Just to show you, to say a little bit of twin-to-twin transfusion syndrome, I know that from our teaching, we are made to understand that it's actually a problem of blood sharing. But what actually happens is that the two twins will fail to handle the fluid due to the communication vessels, so that one twin will end up with a lot of fluid, while the other will end up with no fluid. This will have an effect at the cardiovascular level of these twins, so that one will develop fluid overload, one will develop fluid deficiency. Then the question is, how then do we identify and stage the TTTTS? Stage 1 of TTTTS, we have a situation where the donor bladder is visible, and there is positive end-diastolic flow on both vessels, but there's a discrepancy in the fluid. Sorry, I skipped fluid there. There's a discrepancy in the fluid. One is oligohydramnios, the other one is got polyhydramnios. So this is TTTS stage 1. At basic scanning level, this is what we want you to pick. We want you to be able to detect stage 1 TTTS, because it's very easy to detect for anyone who scans, because it's an issue of measuring the amniotic fluid in the two sexes that you'll be looking at. So that's stage 1 TTTS. Oligohydramnios, polyhydramnios. One of them will have a deepest pool of less than 2, the other one will have a deepest pool of more than 8, or will have a difference in amniotic fluid of more than 6. If you do the deepest pool, you remember we said in twins, we do the deepest pool, we don't do AFI. Then stage 2 TTTS. Stage 2 TTTS, the donor bladder is not visible, and there's two normal umbilical artery Dopplers, while the recipient may appear to have a bigger bladder. Stage 3 TTTS with an absent end-diastolic flow, reverse end-diastolic flow in the umbilical artery in one of the twins, whether that be recipient or donor, there is an abnormality there in the Doppler. Then stage 4, we now have presence of ascites or hydropsy in head of the fetus, usually the recipient. Then stage 5, which I didn't put here, is the demise of one twin. One of the twins dies, or both of them die from TTTS. To be honest, if we are doing the screening program very well at basic level, we do not want TTTS to be picked at this level. It should be picked either here and here. The moment we begin to pick TTTS at this level, that means our antenatal care program is not the right one, because which means we're only picking up when the baby is about to die, and interventions may likely not work. Right, then when you are scanning monochorionic pregnancies, because we know what we are looking for, we are looking for the evidence of selective fetal growth restriction, number one. So how then do we screen for selective fetal growth restriction? When you are measuring, we normally compare the measurements as we do them. We normally use dual screens when you are scanning monochorionic, so that we compare the tummies, because remember we said the tummies are the ones that are affected most in cases of placenta insufficiency, but we know that in monochorionic pregnancies is the unequal sharing of the placenta that occurs. So we compare the fetuses, like you can see in this case, we are comparing this fetus tummies, we're more likely comparing to each other. The other one was 255 and the other one 267. Of course, you also look at the nomogram. This is one of our cases where the selective fetal growth restriction. Look at the size of the tummies. This one appeared small, this one bigger. Of course, it's difficult to just by glancing, but one was 174, the other one was 180, but we need to look at the nomogram. This is just to show you how we check the tummies and to compare them to each other and see how they are growing. But overall, we will then do the weight and plot these twins on the nomogram. These were the these twins came at 29 weeks, monochorionic there. And you can see the weight there, that there's a discrepancy in the weight of the twins, as shown here. The other one was small. This is the one with the green mark there. These twins were small. Almost everything was small for this twin. So there was selective fetal growth restriction here. Then in terms of staging the selective fetal growth restriction, there's actually a staging when we are talking of monochorionic. This is not part of basic scanning, but because the students are also attending, I'll just mention it. Then for the stage one, when you are dealing with selective fetal growth restriction, it's slightly different from singleton in the fact that they are communicating vessels. So because of the communicating vessels, the umbilicatory Dopplers appear a little bit bizarre. So in stage one, we just have a reduced end diastolic flow in the umbilicatory with a very high PI. Then in stage two, we have absent end diastolic flow. Then in stage three, we'll have intermittent present to absent. This was one of our baby there. We'll have present to absent end diastolic flow. This is actually a very bad stage. The baby will be about to die when you see this kind of stage and they need delivery. So you just need to be aware that when you are looking at fetal growth restriction, chorionicity is very important. Dichorionic is just like singletons. This is why I'm not talking much about dichorionic, because it's just less good as singletons. When you are looking at fetal growth restriction, the interpretation is the same. There are some who are asking and say, what is absent end diastolic flow? This is absent end diastolic flow, and this portion is reversed there. I hope I have another very good reverse in the preservation. But this is reverse. This little thing you see there, that's a reverse end diastolic flow. Then, of course, that is fetal growth restriction. I'll come to the definition just now. Then in terms of screening for TTTS, all you need to do is to do the two amniotic fluids and compare them, as you see there. We look for the deepest pool in twin 1, and then we look for the deepest pool in twin 2. Then we measure the deepest pool the way you should do it, from amnion to the baby in this case. Then from amnion here to the baby in this case. These are the deepest pool. Of course, trying to avoid cutting across the umbilical vessel or the limb there. So this was the measurement. You can see these ones we're comparing nicely. Then this one. So sometimes when you are scanning the monochorionic, you'll see this kind of patterns here. We call this membrane folding. This is membrane folding. It's also a sign of TTTS. So if you see the membranes folding on each other, on themselves in twins, this is called membrane folding. It's a sign of TTTS. These babies will need to be referred to a fetal medicine unit for further assessment and management. So that's twin-to-twin transfusion syndrome. It's a sign of twin-to-twin transfusion syndrome. These membranes should never fold on themselves like this, as shown here. Then we also look at the bladder. Remember, we said stage 2 big bladder, small bladder. So the bladders have to be compared, as you see on one of our patients. So we are comparing the blood of twin 1 and twin 2, always colorize them so that we don't mismatch the image. So when I was scanning twin 2, put a different color on the machine there. So, so this twin 1, twin 2 bladder that we are looking at, and this was one of our baby with TTTS. So you can see twin 1 bladder clearly. When you look at twin 2 bladder, it's very tiny. That's a tiny bladder there on twin 2 there. So this was twin 2 stage 2 twin to twin transfusion syndrome. Then we said you compare the umbilical Dopplers for stage 3 TTTS. Probably this is not beyond the basics, because we said the basics don't do much of umbilical, but I thought I should mention it for the benefit of the students in the audience. So this is normal umbilical artery there for twin 1, as you can see. Then for twin 2, you can see this is now reverse. This was umbilical artery for twin 2 now. This is now reverse and diastolic flow. You can see it's looking very abnormal. Look at this. This is normal, but this is now reverse and diastolic flow. Very high PI of 3.95. This is why we say we don't use the resistive index very much. It may deceive you because it was always say at 1 because of the formula, but the PI will continue to go up. If you compare this PI there and the other PI, you can see even the waveform will tell you that there's something grossly abnormal with this baby. So this is the reverse and diastolic flow to the students who were asking the other time. And this was TTTS stage 3 on one of our babies. Then there's a condition which I mentioned, which I called twin anemia polycythemia sequencing. The condition is, then how do we screen for this condition, or how do we diagnose it? This condition is probably beyond the basic course, but I'll just mention it because of the students again. So with TAPS, which is twin anemia polycythemia sequencing, what we do is we measure the peak systolic of the middle cerebral artery. So when you are doing middle cerebral artery Doppler, the figure that we look at now, when you are screening for TAPS, we look at the peak systolic velocity. This is the peak systolic velocity you see written here, PS. For this twin 2 here, which is written B, it was 45. When you look at twin 1 there, it was 75. So there is a discrepancy, but this is not enough for the discrepancy. We go on now to put, if you go to perinatology.com website, if you don't have a nice software to calculate, especially the Volition software, calculate what you call the multiples of median. We use this website because we don't have the software to calculate the multiples of median for us yet. So we go to this website, perinatology.com, then we enter the number of weeks, then we enter this value we call the peak systolic velocity here. Then when you say calculate, the machine will give us the multiples of median here. So the multiples of median which we get, sorry, what have I done? So the multiples of median which we get, if it is less than 0.8, it will signify that, look, this baby flow, there is fetal overload on the baby with a low multiples of median. If the other one is greater than 1.5, that means there's anemia on that baby. When there's anemia, the peak systolic velocity increases. When there's polycythemia, the peak systolic velocity falls because of the taking of blood, because this blood is heavy, because there are lots of erythrocytes in that blood. So it flows at a heavy pace, while thin blood flows at a higher velocity. So this is how we screen for TAPS, and how we also diagnose babies' TAPS and do surveillance. Right, then this is just showing Doppler comparing again for twin. These are the ductus venosas for one of our twins. We had a problem. So you can see it's almost absent A wave in the ductus. This is almost normal. A wave, of course, the PI problem may be on the height, depends on the nomogram. But to just show you again the comparison of the ductus venosas on the twins. But this is beyond basic course. But because they are students, we need to address some of these things. So After doing the weight of the two twins, the question now is, how will you know now that the weight that you have calculated, there is a problem in growth of the twins? This applies to both monochorionic and dichorionic pregnancies. So what you do to get the weight discordance, you say estimated fetal weight of the bigger twin minus estimated fetal weight of the smaller twin divided by estimated fetal weight of the bigger twin times 100, then you get the discordance. If the estimated fetal weight discordance you have obtained is greater than 25%, then indeed there's selective fetal growth restriction. That's number one definition of selective fetal growth restriction. However, if the dates have been verified and you are sure that the pregnancies are where they are, and both twins or one of them is below the 10th percentile in terms of estimated fetal weight, then in this case, there's selective fetal growth restriction irrespective of the difference in weight. So in other words, there are two definitions. One, you can use the estimated fetal weight discordance because we are saying these babies are from the same mother, they should grow more or less the same way. If there's a discrepancy of more than 25% of their weight, then surely there is a problem of growth of one of the twin. This is what we mean by selective fetal growth restriction. We are saying fetal growth is affecting one twin and sparing the other. But bear in mind that you can also have fetal growth restriction affecting both twins, as I have shown you in our own cases. That we had cases where both fetuses had fetal growth restriction. Then amniotic fluid discordance. If you measure the amniotic fluid you subtract the amniotic fluid in the fetus with the biggest pool from that with the smallest pool. If the difference is more than 6 centimeters in terms of the deepest pool, then in that case there's amniotic fluid discordance. The patient will have screened positive for TTTTS and they'll need to be referred to a specialized center. Then where there's oligohydramnios, polyhydramnios sequencing, where one is a pool of less than 2 centimeters, one is a pool of more than 8 centimeters. Again, this patient is screened positive for stage 1 TTTTS and they need to be referred to a specialized center. Then bladder discordance, this is a subjective assessment as you saw from our image. So it's more of a small bladder, big bladder kind of subjective assessment. But we are saying we want to diagnose TTS at stage 1 and stage 2 and refer for further evaluation. The moment we begin to pick TTS stage 3 and 4 at a primary level or at a basic scanning level, then that means we have a problem. Then I think I've already mentioned this. I've already taken you through steps. I've already taken you through stages of a selective fetal growth restriction and also how this works. Probably just a repeat slide. Then the other issue we should be worried about is preterm birth, because twins are at high risk of preterm birth. Therefore, it follows that whenever we scan twins, we should always do the cervix, measure the cervix and see how long the cervix is. We recommend that the cervix be measured transvaginally. However, we are aware that the skills for transvaginal may not be present yet, and also some machines may not have the transvaginal probe. So transabdominal may be done following the recommendation that we said from the first presentation, but you should try by all means to measure the cervix to see an open cervix. Open cervixes in women who have no previous risk are common. This is one of our recent images where the woman came for an anomaly scan and we asked her if we could do a cervical assessment, and this is what we got. A 17mm cervix with a funneling there. So even women without risks, you should always offer them a cervix, more so in twins because of their high risk of preterm birth, which I showed you from the first presentation. Then twins are special. I know that most of our antenatal care, this is the problem which I also have with our Zimbabwean antenatal care protocol, that we are not making twins special. so that we do not have anything special for twins yet in our antenatal care protocol. But all the other people, if you look at the RCOG, the FIGO, the ISOC, the NICE guidelines, they all came up with guidelines that are specific for twins, because they have noted that twins, if they are not cared for in a special way, you are going to have a lot of mortality with your twin pregnancies. So that in one of the surveys done in our own country here in Zimbabwe, they noted that 1 in 5 twin women, they will not go home with 2 babies. This is how bad it is if twins are looked after like any other pregnancy. Therefore, that follows that we should now discuss and say, when you are looking after twins in our hospitals, in our countries, how then should twins be looked after? Twins should have a special care plan, which is different from singletons. So when they come at 11 to 14 weeks, this is where we should determine chorionicity by all means possible. Chorionicity should be determined at 11 to 14 weeks. The moment we discover that there are dichorionic pregnancies, then this is where the issue of dating and labeling should happen. Of course, countries that afford public health or aneuploid screening, then you should offer aneuploid screening. But I'm aware that most countries cannot afford this yet. Then the next time we should see these patients, because twins, you cannot assure a twin pregnant woman that your babies are okay because you've palpated their tummy. It's impossible, guys. There are 2 babies in there. So that means twins are going to require more regular scanning than any other pregnancy. So for dichorionic, how often then should they be scanned to look for the complication that we have just gone through? Then dichorionic should come again after 11 to 14 weeks at 20 to 23 weeks to screen for fetal anomalies and to do cervical assessment and to also assess how the twins are growing. Then from there onwards, they should be seen ideally every 4 weeks till 36 weeks. What are we looking for? We are looking for selective fetal growth restriction. We are looking for the risk of preterm birth. So they need cervical assessment when they come. So we do Dopplers for all of them, but I'm aware that other centers may not be able to do this. But those who are not able, do biometry and see if indeed there is no fetal growth restriction affecting one of the twins, because it's the leading cause why dichorionic diamniotic babies will die. And also check the cervix to see if the cervix is not already opening, because the human uterus somehow feels that the twins are too heavy and the cervix tends to open earlier than in singletons. Then delivery, there are studies which I didn't show in this presentation because of the level of the presentation, but it has been shown that if we leave twins on their own to deliver when the woman feels like labor is come, we are going to have a lot of mortality if we leave the twins to go all the way to 40 or 42 weeks. As a result, international guidelines recommend that we deliver the twins if they are dichorionic diamniotic around 37 to 38 weeks. And this is what we recommend here in Zimbabwe as well. Whenever we see twins, that they should be delivered between 37 to 38 because of the increase in mortality after that. What about monochorionic? These are special pregnancies. Ideally, monochorionic should be seen in a specialized center, but I'm aware that not all hospitals will have access to specialized centers. Then 11 to 14 weeks, we should do the same thing. We want to date the pregnancy, and we should determine chorionicity at 11 to 14 weeks. Then we label the twins. If we afford aneuploid screening, we offer aneuploid screening. Then we ask these ladies to come again. Sorry, this is for DCDA. I should go to mono. Yeah, mono here, right. So then we ask them to come again as early as 16 weeks. Why 16 weeks? Because we want to screen for TTTTS. TTTTS starts manifesting as early as 16 weeks. So we want to check for amniotic fluid discrepancies. We want to check for fetal bladders from as early as 16 weeks, because this is where TTTS can start. From there onwards, we want to see them every 2 weeks. Then around 20 weeks, we do the anomaly scan. We do the cervix as always when they come, and we will be screening for TTTTS, selective fetal growth restriction, and TAPes. This is why I put all the Dopplers there. So the ideal place for monochorionic pregnancies to be looked after is within specialized centers. This is why it is very important at primary level to be able to determine chorionicity so that you know which pregnancies you should be looking after and which pregnancies you should not be looking after. Because the embarrassment that always comes is if you look after these pregnancies at a center that is not specialized, they will develop TTTS, and in most cases, the patient that you have been looking after and reassuring that everything is fine, they'll present to you to one of the babies already dead or one of the babies already with fetal drops, fluid everywhere, because TTS is set on. So it's very important to be able to distinguish dichorionic from monochorionic pregnancies. The good thing is that only a third of the pregnancies are monochorionic, the 2/3 are dichorionic. So the majority are pregnancies which can be looked after at a lower center, while the monochorionic should be looked at a center that has specialized services. Thank you so much. That's the end of my presentation. And of course, delivery 7 weeks for monochorionic.
Dr. Verenga, thank you so much. You know, when you are presenting, I'm actually smiling from ear to ear because all those things which when I was going through my training, the things which were so difficult to understand, the chorionicity, it was so difficult, but you make it so easy. Thank you so much, and I'm so glad that you have gone through this topic because there's a lot of questions from, more especially in Limpopo, about this kind of service. Are we giving those services? Because I'll give you an example. When I came to Limpopo, for example, people said there is no pelvic organ prolapse on Black women, right? Because we were not looking for them. People didn't know what to look for, and people didn't know that there is help. As a result, when one comes, we have all cases which are booked up until next year with pelvic organ prolapse. So the questions which are coming from the floor, it's you know, we haven't been looking for these twins, and we haven't been looking for assessing those twins. I'll give you an example from Dr. Mushopia. He's asking, Dr. Verenga, most of the times we manage twins at a district hospital. What are the guidelines? And actually he was saying, what are the guidelines in Limpopo per se for patients with twins? I know this one is directed to us. So I'm not sure if you would want to say something before I would answer Dr. Mushopia.
Dr. Takalo, I think this is the reason for these meetings, to inform each other that, look, guys, it is up to us to do the right things, because I've already told you the testimony from my own country in Zimbabwe that our antenatal care protocol does not single out the twin pregnant women for a special care. They are all lumped together with the singletons. But because of that, we have a high perinatal mortality among the twin babies because of that. So this is why I'm presenting and saying, look, guys, we need guidelines for twins in our region. In Europe, in the Americas, they have already sorted this issue out because they noted a long time ago that twins cannot be cared for in the same way as singletons. It is up to us now to align our guidelines so that we can start to do something about twins who are twin babies who are dying in a way which I think we can prevent.
No, absolutely. And to answer Dr. Mushopia as well, to be honest, the reason why we went all the way to Zimbabwe to ask for Dr. Verenga is because for the whole of Limpopo, we do not have a specialist like Dr. Verenga. But I must say, we've got a very progressive MEC, Dr. Poppy Ramatuba, was with us on Wednesday. She has already sent one of our specialists from Limpopo to Pretoria to go and learn. It will take at least 4 years for him to be able to be qualified and be like Dr. Verenga, but he will be coming in and out. He goes to Pretoria every 2 weeks and come back. So when he comes back, he at least has some form of knowledge on this thing. So to answer your question, Dr. Mushopa, at the moment, we do not have this kind of facility. And I think Dr. Kopa from Kula, from Tabazimbi also asking, do we have the fetal medicine clinic in Limpopo? At the moment, we do not have, but we are working on making sure that we have it. But that's why we are asking people like Dr. Verenga to be able to give these talks and conscientize us on these issues. Yeah, so any comment, Dr. Verenga? You can go ahead.
Look, I just want to cement what you are saying, that look, even in Zimbabwe, we didn't have this service, but we are now there. We have to build block by block, and to one of the reasons why I say I'm passionate about presenting, I know that there are young doctors who are listening to me right now. I want to challenge them to say, look, guys, there is something called fetal medicine. Please choose fetal medicine for a subspecialty, so that we can save both the women and babies of Africa. Yeah, we need more people who love fetal medicine and who practice it.
Absolutely. And I must say, Dr. Verenga has extended his hand, and when the coronavirus is finished, we're going to bring Dr. Verenga, and we will take him to all the hospitals in Limpopo, so that now the practical part, which we are currently not able to do because of the virus, we will be able to do. So there is all the plans. While we're waiting for our own people and you young people to get trained, we are pushing on. And what Dr. Verenga, you said about the guidelines, not only for a country, for a region, for Southern Africa, we should come up with something like that, because we have the same challenges, don't we?
Yeah, we do.
Yeah. Julia from Namibia, Julia from Botswana, do you want to have a comment on this, please? Go ahead.
Thank you, Dr. Dakalo. No, it's always good to attend. It's always good to remind ourselves. One of our people like us have done this in class, and it's still good again to do it again. So I'm happy to see that people are still busy, interested again to learn. So we soldier on. We are also waiting for him to come over when all this is done. I mean, when the COVID-19, we have ways to tackle around it. So thank you, Dr. Verenga. That was an awesome presentation. And we look forward to do the practicals with you.
Absolutely. We've got a student from Zimbabwe. The student says, thank you, Dr. Verenga. Your teaching was very good today. And another person saying, hi, Dr. Verenga. Thank you for the wonderful presentation. I work at a district hospital in Zim, where ultrasound is not available at hospital, and it's a privilege. What do you recommend we do when we meet a woman with twin pregnancy? Dr. Verenga, this question is back to your home country. They want to know, what should they do?
First of all, I'll be interested to know which district hospital, because as far as we know, we've trained everyone from every district hospital in Zimbabwe, and they were given machines by the Ministry of Health to go and scan babies. So I'll be interested to know which district hospital is this one, because it will be a shock, because all the district hospitals were trained and given machines. So yeah, so I don't know which district hospital is this one, to be honest, because I don't know how they were missed. If they are there, they can indicate to me which district they are, so that I can take up the issue with the authorities.
Yeah, absolutely. I think let's do that. I think from the team, everyone who's listening, let's be proactive like that. When you find that you might be in a corner where some of the services are not coming, come forward. And half of the times, Dr. Verenga, our MEC will tell you that those stuff which well, ultrasound, someone will be logging them at the storeroom and not using them because they don't know how to use it. So sometimes you may find that's that element as well. But let's go to another question, please. We've got Anonymous. Anonymous is saying, can the weight of twins determine the mode of delivery? Example, a preterm labor twin with dichorionic diamniotic twins, both cephalic with estimated fetal weight of less than 1.5. Is it safe to do NVD or Caesar? Actually, it's not anonymous. This is our registrar, Dr. Mabatswa from Mankweng Hospital. Dr. Mabatswa, thank you so much. Go ahead, Dr. Verenga.
Yeah, so when it comes to delivery, delivery of twins, there are what we call rules of thumb, right? If the leading twin is a breech, we normally don't recommend that these twins undergo any form of vaginal delivery, number one. Number two, the delivery for dichorionic twins, if the leading one is cephalic, and there is facility for the preterm, I'm referring to I think they mentioned preterm. For term twins, cephalic, leading cephalic, is better to allow them to deliver vaginally. But for the preterm now, and the leading is cephalic, if we have facilities to monitor, they can still be delivered vaginally, and we have good, of course, good neonatal care to look after these babies when they come out. If you don't have them, then you rather refer to a center that can offer neonatal care services. Then for the monochorionic twins, it's always a little bit risky to try and deliver them vaginally, even if they are presenting in the normal, in the cephalic presentation, because there's always dangers that the remaining twin may actually distress, go the placenta, since it's one placenta, it may separate before it comes out. People fear that. So that you should do it if you can monitor the twins. You have a very good monitoring technique, equipment like continuous electronic fetal monitoring. But if you are not able to monitor, then it's not the safest thing to do to try and induce them or to deliver them without the ability to monitor. So for monochorionic twins, it's safer sometimes to deliver them vaginally if you are not by cesarean section, if you are not able to monitor, especially the other twin who remains. I think I've answered the question in a way through my answers.
Yeah.
But if
Dr. Verenga, this part excites me, to be honest. I've got a doctor here, actually it's a radiographer from Tanzania. Yes. Listening to you, my chief, Dr. Verenga. This radiographer is saying, thank you, Dr. Verenga. Your nice presentation. I'm a radiographer from Tanzania, was following you. Oh my God. I mean, what more can we say? We can just close and go home. It's all done. Okay, but we can't close now, Dr. Verenga. I've got more questions which I need to really squeeze in. We've got Selo Rasello. This gentleman, he has told our MEC that he wants to come with me to Zimbabwe. So Selo Rasello is saying, dichorionic diamniotic twins, twin A demise at 28 weeks. How do we manage that patient? Salo, thank you so much. Let's go to Zimbabwe, friend.
Right. So look, I'll address it. Like I said, that it's a basic course, but because of the registrars and trainees in the group, I have to go a little bit deeper there. So look, if one of the twin dies in a dichorionic diamniotic twin pregnancy, the pregnancy has to continue. In dichorionic pregnancy, the risks of damage to other twins, of the other twin, if indeed the cause of death, let's say probably the other twin is die from infection like torches, there's a risk that the other one could be infected incidentally. But if it is a cause which is just isolated to the twin who has just died, that means the other risk is not that, the other fetus is not much at risk because there's no sharing of the placenta happening there. So this pregnancy can go all the way to around 38 weeks, then delivery can be instituted. Of course, the cervix always has to be checked because there's always a tendency that if one twin dies, sometimes the cervix tends to start misbehaving. So the cervix has to be checked so that if labor is imminent or threatening, you can give the other baby steroids so that it benefits from antenatal steroids before delivery. Then for the monochorionic, which I have to address because the question has been asked, for the monochorionic, if one twin dies, then the other one is now at risk. Why? Because I told you that there are communicating vessels between the twins. So this communication, there's going to be a pressure imbalance because the other one, there's no more heart pumping blood to maintain some balance. So the other twin is likely to bleed out blood to the dead twin. And this hemodynamic imbalance will cause brain injury to the other twin. So there is always a very high risk. Normally we tell mothers, that couples, that the risk can go as high as 25 to 30% that the other one will have brain damage from the death of the other twin. So these twins, if they are not at a safe age to deliver, they will need to be monitored with Dopplers, especially the mid-cerebral artery Doppler, like I showed you there, to look for evidence of anemia because the other twin may bleed, and also to look for evidence of brain structural changes. But in most cases, there will be brain damage to the other twin. And unfortunately, rushing to deliver the twins does not necessarily save these babies from this brain damage because it's not known exactly when it happens. Even when the brain looks morphologically normal, we always tell the expecting parent that there is always that risk that this other baby could have some neurological handicap from the hemodynamic imbalances that come with the death of the other twin.
Super. So there's someone here who really wants you to help him with his business. If you can able to help him to be able to check the sex of the baby, can you show us some scan for the sex of the baby? Because that's so important. Parents they're not necessarily interested on whether there's a fetal heart. They just want to know if it's a boy or girl. Can you show us some scan for that, please?
I think I showed when I did the anomaly survey. I think I showed you the sex of the baby, but right, probably to respond to public demand, let me stop the share of the screen. Let me just show you the pictures of the sex which are in our lab. I'm sorry, I can't show you because they are not anonymized. They still have patient details, but I'll show you in the next presentation. I'll make sure I'll show you in the next presentation the fetal sex, how it looks like. Yeah, of course, we normally don't encourage people to always want to review the sex. I know this is what parents need, but because people may misinterpret the gender and cause women to be super angry when they paint their rooms in blue and they are supposed to be doing it in pink. So yeah, but I'll show you the pictures in the next presentation. Unfortunately, the images are not anonymized, so I can't show them to you. Thank you.
No problem. Got it. So let me squeeze another few questions, please. Bona is saying, very informative, Dr. Verenga. I have been enjoying all your sessions. I am coming from University of Zimbabwe, CHS. I don't know, I'm not sure what is CHS, Dr. Verenga?
College of Health Sciences. It has recently been changed. It's now Faculty of Medicine and Health Sciences.
Yeah. Okay, good. Dr. Bona, keep on listening to Dr. Verenga, and on Wednesdays, we also have the ESMUS. You must also join that as well. Okay, so we have Uranga Daniel Amboy. He's saying, you showed us about the chronicity. Please tell us when the division of triplets, you know, from the time of zygosity, when does that happen?
The triplets is the same issue. Let me go back to the presentation. I think it's easier to explain with the presentation on the, which one was I showing? I think it's this one. So if I go back to the presentation, the triplets is the same issue, but in this case, we may have a dizygotic situation, but the other one will continue to divide. In a dizygotic, my slides are refusing to move. Let's see. Oops. And sure. So Screen sharing is stopped. Just a second. So if I go back to these images here, I think it's better to explain with the first image, which is this one. So if I go to this image, all I'm saying is that in this scenario, where the dizygotic impregnation that was occurred, but it has not divided. But if one of them divides like this, we may end up with a triplet. Are you getting it? We may end up with a triplet because this is divided. We also have situations where a monozygote can also divide into 3 again. In the same manner. Are you getting it? Yes.
Yeah, I got it. I hope that
but the triplets I've come across the ones, I mean the monozygote, I've come across with it with a single amnion, which probably mean it might have divided around day 9, day 12. But the majority will be from this. Dizygotic, one of them divides, the other one remains the same.
Okay. Dr. Mshopa hasn't got enough of Dr. Verenga. He's asking, Dr. Verenga, is there a course offered in Zim for obstetric ultrasound? Or maybe is there some water you are drinking so that you can understand this obstetric ultrasound easier?
Yes, we have started a training program, and we've also registered some programs with the University of Zimbabwe, which will be launched very soon to train people in obstetric ultrasound. So we've started, we have our specialists who are training. We also have got students who pass through us. We've started training people in obstetric ultrasound since we opened the fetal medicine unit. So we've started the program.
Lloyd is going. Beautiful. Lloyd is going to kill me if I don't ask this question. Lloyd has been attending our lessons from Wednesday and Friday religiously every day. So Dr. Zondo, thank you so much for doing that. Dr. Zondo asked, 30 to 50% of perinatal deaths actually occur in low-risk pregnancies. Since umbilical artery Doppler is associated with reducing perinatal mortality, should every woman be offered the umbilical Doppler ultrasound, and at what gestational age? You got the question?
Yeah, I'm getting the question. It's a good argument. I'm from fetal medicine, so I would want all babies probably to be thoroughly evaluated. But what you find out is that the majority of women may not need to have Doppler done if the growth is normal and they are indeed low risk, like we said from the first presentation. So that the benefit of doing umbilical Dopplers in an appropriately growing babies is not there. But what we need is to strengthen the identification of high-risk pregnancies, which you are not. How then, especially more so in Africa, where the majority of the women are of the black race, it is important that we strengthen the screening for placenta abnormalities like preeclampsia and other causes. This is where the issue of the uterine artery, I think we are aware that FIGO is already okayed or is already recommended that we should now screen for preeclampsia in first trimester using quite a number of factors. One of them is doing mean arterial pressure and also uterine artery Dopplers. I think this is where we need to strengthen, because we are missing the at-risk group, so that we are managing as a low-risk group, and they end up with poor outcome because we have missed that this woman is a high risk, because our screening methods we are using based on history alone only picks up 30% of women who are at risk of having small babies or preeclampsia.
Agreed. Let me remind you, Dr. Verenga said, if you do a scan and not say the chronicity for multiple pregnancy, you actually didn't contribute much on the management of the patient. Yes. I thought that was very powerful.
Correct. 100% correct.
Yes, and then
chronicity.
Yes, and then Enis Ziki says, what is your take in induction of labor for diamniotic, dichorionic diamniotic twins, especially where a CTG is not even available?
Induction of labor can be done in twins. The biggest problem we have, I don't know other countries represented here, but the biggest challenge we have in Africa is that we are using cytotech for induction, or misoprostol. Misoprostol causes overstimulation of the contractions, which is not good for twins. But if we have the sort of the more proper agents which are used in the West, which don't cause hyperstimulation, it is possible to induce twins. But with cytotech, it's always tricky because you don't want contractions to be worse once the other twin has come out and the other one is still there. There are lots of contractions. You may compromise oxygenation of the remaining twin because of the effects of cytotech.
Lovely. Nzalama is asking, is saying, what if the other people are interested in joining this webinar? What must I do? Nzalama, you can ask them to send me a text and then I'll send them the link, or they can go to our social media. They can go to Dr. Mwaba YouTube, and out of those recorded sessions, there's also a link for Dr. Verenga's session. So there's a lot of opportunities for everyone to join us, and we want everyone to join us. Dr. Omahi Onwe said, Dr. Verenga, please, how do you screen for aneuploidy? Because you've been saying about screening for aneuploidy. Would you like to answer that, Dr. Verenga?
It's a long topic to answer it in a session like this one. But screening for aneuploidy, we're talking of screening for Down syndrome, Edwards and Fetal, and of course others like monosome X, which is tenus, and also triploid E. Screening for chromosome abnormalities, we know of the first trimester screening program, which was sort of strengthened, pioneered and strengthened by Fetal Medicine Foundation under Professor Kyprios Nicolaides, which the rest of the world is now doing. So we can screen for all these chromosome abnormalities by doing a first trimester scan between 11 and 13 weeks, where we have measured the nuchal translucency, which is fluid behind the baby's neck, which I showed on one of the on these two babies here, where we measured this fluid. I think the next image is better. Where we measure, like we measured on these two of our babies. This is the nuchal translucency, which we measure, and we combine this nuchal translucency together with the woman's age. In our case, we also do the ductus venosus and the tricuspid regurgitation. Then we'll send the woman to the lab for PAPA and beta ECG. Through that, through the calculation with all these factors, we'll be able to tell a woman whether her pregnancy is at risk of having any of these syndromes or not. This is the risk calculation. Then if the woman comes as a high risk, then you can offer them a diagnostic procedure, which can be a CVS, coronary villus assembling, or amniocentesis. That's number one. But in nowadays, in 2020, we have a newer method of screening for aneuploidy, which is called fetal cell-free DNA test, where you just need to take the blood inside the woman's blood from 10 weeks of pregnancy. And through that test, through complicated laboratory mechanisms, the laboratory is going to tell us whether the woman's baby is at high risk or not of Down syndrome, Edwards, or Fetal. And this test can also tell the gender in terms of XX or XY. So in summary, that's screening for aneuploidy. It's a topic on its own, a long topic. Probably we'll slot it on the further trainings that will come after these basic courses. Thank you.
Beautiful. I wanted to tell everyone, because now it's 18 minutes after 4, but people are still staying because they really enjoy your talks. And thank you for staying, everyone. I just want to tell you that this is supposed to be the second last presentation by Dr. Verenga. And I don't know if it's enough, but for me, I think I am still learning a lot and I need more of Dr. Verenga's Fridays. So if you would like Dr. Verenga to continue on some of the topics, please can you send me the suggested topics you would like him to continue with? And he would also go and think about how much he can actually bring more to us, because we really want more. And Dr. Verenga, the time is almost finished. Can I ask Julia to just say her last words, and then Dr. Verenga is going to say the goodbyes for us. Dr. Julia, can you just for your last words, Julia?
Okay, thank you, Dr. Dakalo. Yes, I think people still need more of your lessons, Dr. Verenga. So please organize for us to have more. And I think there are still some new people who have just started and who missed out on the first lessons that you gave us. So I don't know, maybe you can retouch and go back to where it all begins, because when they start at this stage, I think it's a bit confusing for most of them. So maybe you can think about that. And lastly, I'll just say my vote of thanks to Dr. Verenga.
Thank you.
You are actually a godsend. I don't think people would dedicate their time and give us free knowledge as you are doing right now. But we are all pleased and happy that there are people like you. So thank you so much. That was a great presentation. And Dr. Dakalo, thank you for facilitating this as well. May God richly bless you.
Oh, wonderful. Thank you, Julia. And someone is actually anchoring Julia's sentiment. This is Yanga and Kinkwana saying that, thank you so much, Dr. Verenga. May God richly bless you. We are happy to drink from the cup of wisdom from Zimbabwe. Thank you so much, Dr. Yanga, for saying that. We really appreciate that. Just for Dr. Julia and just for Julia and everyone who have possibly missed some of the talks which Dr. Verenga has done. The talks are recorded and already available on YouTube. You can go to Dr. Mwaba on YouTube and you'll be able to access all the talks he has done. But he will be coming with more, okay? More and more definitely will be coming. Dr. Verenga, your last word, please.
Thank you, everyone. Thank you from Tanzania. Thank you. It's an honor to have you here. And thank you, the team from Botswana. Julia, thank you. You are doing an amazing job there. And the Zimbabwean colleagues, thank you so much for taking time to do this. And the wonderful team in South Africa, thank you. Thank you, everyone. Thank you to all the students who are taking their time to learn. Thank you so much. Bye-bye.
You forgot, Doctor, before you go, you forgot Ghana, you forgot Rwanda, they're going to kill us. You forgot Namibia, they're not, Dr. Msusa is not going to be happy. Dr. Valence from Rwanda is not going to be happy. How do you forget those people?
My God, I'm truly sorry. Rwanda, Ghana, we said Namibia,
Namibia,
Zambia,
Swaziland,
Eswatini. Thank you so much, guys.
Evo.
Thank you.
Inkosi, bye-bye. Everyone, see you on Wednesday. Bye-bye.
Bye-bye.
Bye.